Dr. Bahlani can go in many different directions. So I'll give you a little bit of Dr. Bahlani here. Dr. Bahlani went to Richmond University, did her BS in chemistry, and she studied abroad in Rome, very nice. And she went to University of Virginia Medical School. She was a resident in Weill Cornell in 2010 through 2013. She also was at NYU from 2009 to 2010. She has written a bunch of peer-reviewed publications on different topics. And I think the thing about Dr. Bahlani that really drew me to her is her ability to relate to patients, her knowledge, her ability to help. And I think that is a key in today's world, being able to connect with people. So, and this is the first of hopefully a series that we're going to be doing on Zoom meetings on different topics. And we chose Dr. Bahlani to be our first. So thank you, Dr. Bahlani, for joining us. Thank you for donating your time, your knowledge, and your expertise here.
I'm honored. Thank you for having me.
So for people who do know me or do not know me, my name is Phil Altman. I'm one of the pharmacists at Healthy Choice. We're a closed-door compounding facility, and we've been doing compounding since 1997. About 5 years ago, we left our retail bones and we jumped right into just doing compounding because that was our passion. That's where we felt we had the biggest impact in helping people. We built out a state-of-the-art USP 800 compounding facility, and our goal is to specialize in personalized medicine. And we really feel personalized medicine is the medicine of the future. We don't fit a round peg in a square hole. We really try and fine-tune that medication for each individual patient, whether it's the base that they use, the delivery system they use, or just the dose of the medication. Not everybody can take the same dose of the same medication. And one of the things that we're really about it, we're dedicated to what we do. And this is one of the ways that we're dedicated. We're providing great information. Dr. Bahlani is going to provide cutting edge information that you can't get from many people. We're here to educate and disseminate current information. But the thing that we do best, I think, is that we create. We give physicians like Dr. Bahlani more tools in their toolbox so they can help more patients. And that's really what it's about. And some of the ways that we help are for women with bioidentical hormone. We treat men with andropause. Next month is Thyroid Awareness Month, and we're going to have a Dr. Carolina Sierra, who's an endocrinologist, talk about Hashimoto's and thyroid replacement, talking about low-dose naltrexone. We also have a pain management doctor who's going to be talking about low-dose naltrexone as well. And and on the right side are some of the different delivery systems that we can use for patients. Do they need it in a cream? Do they need it in a capsule? I've made gummy bears for kids because they couldn't swallow a capsule or a tablet. So it's really about digging in, finding what's going to work, and making it happen for that patient. And this is who we are. If you have any questions, you can email us, you'll text Corinne, but that's just us in the skinny. And now I'm going to turn it over to Dr. Bahlani because she's really the person you guys won't want to hear.
Thank you.
I will stop sharing my screen and it's all yours.
Okay, perfect. So let's do this. Share screen. Hold on. How does this work? Share screen. There we go. Here we are. Okay, and then let's do slideshow from beginning. Got it. Okay. So a lot of people are probably thinking when you're watching this, first off, you know, why is a physician talking with a compounding pharmacy about pelvic health? And the truth is that pelvic health is one of the most ignored topics in history, whether that relates to men, women, or both. And oftentimes, the reason that Phil and I really connected is because treatment modalities really depend on thinking outside of the box. And oftentimes, just like he alluded to, you have to use things like suppositories, different topical creams, and you really want to make sure that what the ingredients that are being used are, effective, are absorbed appropriately. And so and I'm not a pharmacist by training, right? So I will often call Phil and say, hey, listen, I have this patient. I really want to do this with her, but she's really sensitive to this medication. Can we compound it in this? And he'll say, you know what? I think you should use this base because it'll absorb, but it won't be irritating. And that's really key for any patient to understand because, we can't all do it all. So collaboration is really key. And that just like a little background for anybody who might be wondering kind of how this came about. So today I'm really going to discuss pelvic pain in the pelvic floor because, hey, we're in the middle of a pandemic. I'm sorry, there's a phone call coming. We are in the middle of a pandemic, and pelvic pain and pelvic floor dysfunction is kind of like often off the roof right now. Like a lot of patients are really suffering and they don't know where to turn to or where to go to. And this is a good modality to understand your own care. So I have no disclosures. So why is this topic important? And that's kind of what I was talking about before. It's important because it's stigmatized. And often patients really don't discuss this with their doctors because they think, well, maybe this is just normal. Maybe this is just something that I have to live with. And guess what? It affects men, women, both. So there is no gender norm here that we're talking about. So oftentimes it's highlighted in women just because of the different causes of pelvic pain and pelvic floor syndromes, but that's not necessarily true. I actually see a lot of men in my practice, men who have things called prostatitis, men who have things called interstitial cystitis. So the thing that I want to take home here is that pelvic pain does not discriminate. It can affect anyone, anywhere, at any age. So if you're ever exhibiting symptoms, it's really important to get evaluated by a physician that you trust. So the objectives of today, I like to be really transparent in what I'm trying to get across. I want everyone to have a better understanding on how to approach pelvic pain syndromes, understanding the pathophysiology of certain pelvic pain syndromes. So when you're suffering, if you understand what's going on in your own body, you're more apt to get the most appropriate therapies. We'll talk about some diagnostic strategies and management options. Throughout this, just like Phil said, if anybody has a question, stop me, write it down, we'll talk about it. And then, of course, we're always here outside of this, should you choose to connect, which I'm always around. So why is it so hard to understand and treat pelvic pain or, any type of pelvic health modality? Well, because the pelvic floor is not the only thing that's contained in the pelvis. And so often when we're talking, people are like thinking of the pelvic floor, and here's my little model, and they're thinking just the uterus, or they're thinking just the bladder, or they're thinking just the vagina, or they're thinking just the rectum. Well, hey, guess what? The pelvic floor and the pelvis works as an entire entity. And I saw that someone wrote a question about how GI stuff can affect, like how that can be affected by menopause. Well, guess what? That can also affect bladder-based symptoms. That can also affect how painful intercourse. I mean, there's so many different avenues with which this can go. And it's important to understand that and look at the body as a whole, not just little pieces. There are different causes of pelvic pain, and we can talk all about that. For men, with pelvic floor dysfunction, we call it category 3B CP, CPPS, or chronic prostatitis, chronic pelvic pain syndrome. There's something known as interstitial cystitis bladder pain syndrome, pelvic floor dysfunction, and of course, vulvodynia or vestibulodynia. And all of these things, while seemingly different, are actually very interrelated, and we'll talk about how. We'll go over some summary and take-home points, and then any questions that you might have. The one that I'm really going to focus the most on is pelvic floor dysfunction. And the reason being is that I think that it is probably one of the most underdiagnosed entities out there. It's probably one of the most misdiagnosed entities out there, and you should understand why. So it's interesting because I love that question that was asked, because it actually brought this slide into fruition. Like, what is it? Why do patients present? And oftentimes they'll say, you know what, doc, I have pain in my pelvis, but I've had this bad shoulder for a long time too. And it's really weird. It kind of came about the same time that my pelvic pain came about. And you know what? I was recently diagnosed with a hip labral tear. I've been diagnosed with recurrent urinary tract infections, rheumatoid arthritis. migraines, TMJ, and peripheral neuropathy. What's going on? Like, why are all of these things happening all at once? Well, oftentimes, more often than not, they're related, and they're oftentimes related to inflammatory cytokines and how they affect our body differently in different areas. However, they're also a great source of understanding how we can use medications, like certain things that Phil will make, to be super helpful for all of these things going on. I'm sorry, that's my son, he's crying. So pain generators. So think about it this way. When you ask a question about menopause or a question about pelvic pain or recurrent UTIs, you're looking at it from a small framework. And it really brings about this fable. I don't know if you guys have heard this Buddhist fable where it's like the four blind men, and they're blind. And so one guy looks at the trunk and he says, an elephant he tells everyone that it's a big snake. It's not an elephant, it's a big snake, because he's feeling his trunk. And the other guy feels his foot and he says, nope, it's a tree stump. And the next one says, oh no, feeling his ear, it's leather. And the last one looks at his tail and says, oh, it's a furry mouse. And the point is that if you view pelvic health or any type of pelvic floor disorders with a myopic vision. So if you're only looking at one part of the pelvis, you will never understand the complete story, and you will never understand how this can relate to other parts of our body, which is really key. So, pelvic floor dysfunction, every time I talk about this term, the first thing people tell me is Kegels. Kegels are going to fix me, because Kegels fix everyone. And I always say, like, Kegels has the best PR agent ever, because Kegels is actually the wrong thing. You don't want to be doing Kegels, and Kegels can in fact make you worse. And so whenever we talk about pelvic health, the first thing that comes to play is prolapse. But guess what? 80% of patients who exhibit pelvic floor symptoms are actually exhibiting things like urgency, frequency, pain with bladder filling. They could have GI symptoms like constipation, pain when they sit for long periods of time. So, just understand that all of these things are often related, and oftentimes the most common answers that we have received as people out there are actually the wrong ones. So it's just important to know. So some of the most common causes or common symptoms of pelvic floor dysfunction are frequency, urgency, and nocturia. Now, why is that happening? Nocturia means waking up at night. So every time someone wakes up at night, they'll tell me, oh, I have overactive bladder because I'm going to the bathroom so frequently, and that's what my doctor told me. When in fact, the vast majority of them actually have pelvic floor dysfunction. And that's when the bladder contracts, the pelvic floor, which should normally relax, doesn't. It actually spasms and tightens. So now your bladder contracts, your pelvic floor spasms, so you don't completely empty. So you leave a little bit of urine in your bladder. And that's what gives that sensation of persistent urgency, like, I gotta go. I really gotta go all the time. It makes it difficult to start a stream. You require pushing or straining. You can have pain with intercourse, both initial or deep penetration, pain with sitting, or even pain in the rectum or the coccyx. And we'll talk about different treatment modalities, but the one thing where I learned about the Healthy Choice Pharmacy was actually discussing something known as Valium suppositories, which is a compounded medication that has data behind it that's extremely helpful for patients who have pelvic floor dysfunction. And you can't, and so people always ask me, can I just use like a Valium tablet? Can't you just send it to my regular pharmacy and I'll just put like a tablet of Valium into my vagina? And I say, no, because the absorption is totally different. It does not, you want a medication to actually work. And it's like me having a tennis racket and Federer having a tennis racket. He plays a lot better than I do, right? We all have the same tools. It's just how you use them. So it's really important to understand the tools that we have to treat pelvic health syndromes. So, and then I always get the question, like when I'm sitting with a patient in the office and we're going through all this and they're like, what is that? Well, like what can cause that? What causes this spasming? Well, it's this presence of what's called a trigger point. And trigger points are literally taut bands of muscles within the pelvic floor. So we talk about this all the time in our back and our neck and all of that, but we never talk about it within the pelvic floor, but it exists. What defines it in terms of as clinicians is when we do an exam and we feel what's called a twitch response. So we palpate that muscle and guess what? It clicks right back at us. And we're like, whoa, okay, I can see how that spasms in and of itself. Oftentimes, what's contained within these trigger points? Inflammatory cytokines. So things like norepinephrine, substance P, ATP, nerve growth factors. So this is a key reason that oftentimes patients with pelvic floor dysfunction can have other what we call comorbid conditions like endometriosis, interstitial cystitis, vulvodynia, rheumatoid arthritis, fibromyalgia. So we're talking all around the body here. So it's not as like single vision, just the pelvic floor as we think it might be. And that's why even in my own practice, I'll often use things like low dose naltrexone, because you got to think about the whole clinical picture and what you're treating. First line management of this consists of controlling constipation, because think about what happens when you're constipated. You push or strain to try to get that stool out, and you think that that's okay, but what are you doing when you're pushing or straining? Tightening those pelvic floor muscles even more. So patients will say to me, I don't understand why my pelvic pain gets so much worse, or why my frequency gets so much worse when I'm constipated. Well, those muscles are spasming a lot more because you're pushing or straining. Those trigger points are just flaring, okay? And there's also this concept of, and now I'm probably going to lose some people, but there's this concept of what's called visceral-visual convergence. So basically, neurons synapse on the same peripheral neurons that innervate both the bowel and the bladder. And so that's why some patients will even say to me, you know, I feel so much better after I have a bowel movement, or after a bowel movement, I have like this burning in my vagina. It's all related, is the take home point here. Stress reduction is key. Hey, we're in the middle of a pandemic. What do you do when you're stressed out? You clench your jaw. People clench their pelvic floor. It is a headache in the pelvis. It's the exact same thing if you want to really think about it logically. Even when we talk about medications that we use, they all work in conjunction with pelvic floor physical therapy, and that's always part and parcel of treatment and really important. And then dietary changes. I mean, we talk about diet all day, every day now, right? I mean, Phil and I were just talking about this before we hopped on. Yes, diet can have a role in all of these things, not only because it can aggravate the bladder, certain foods can aggravate the bladder and the pelvic floor, but because it can increase inflammatory cytokines within your body. And by doing so, it can exacerbate symptoms of pelvic floor dysfunction or endometriosis or interstitial cystitis. Oh, did I go the wrong way? Sorry, guys. All right, here we go. And then I am all about the data. I think it's really important to me to provide patients with evidence-based approach to treating these things, because there's data behind stuff. So this is just to show you how there are studies that show statistical improvement in symptoms, both in pain and urgency and quality of life surveys in patients who actually do see pelvic floor physical therapists in conjunction with oftentimes compounded medications. And this study was actually the Valium suppository study. So we have so many tools, and just like Phil said, we have tools in our toolbox. And that's the key to me when I'm talking to patients. I'm always like, my goal and my job as a physician is not for you to need me all the time. It's for me to be that voice in your head saying, you know what? I was doing really great and I'm having a flare. Let me go ahead and pop in my suppository. Let me go take a warm bath, pop in my suppository, and put a heating pad on. And understanding your body, understanding what causes flares is really key. And utilizing the tools that we have is like first and foremost the most important thing you can do. And why I assume, you know, if you're watching this today, you're actually thinking about these things. I'm going to briefly go through this. I think it's a little probably dry, but there's oftentimes procedures that we do to help this, things called trigger point injections, and this data is derived from acupuncture data. We use things like Botox. Now, people look at me like I'm kind of crazy, but everything that we do is often off-label, and the reason for that is because insurance companies don't really recognize pelvic health as a thing. And so that's often why when patients ask me, why do I have to pay for my medications out of pocket? Or why is Botox not something that insurance tells me about? Well, because it's one of those things where it's not studied enough by insurance companies for it to be really looked at, and it should be. But to bring that on, this is data that we wrote ourselves, which is, and it was presented at the AUA and the Sexual Medicine Society, taking a look at patients who have pelvic floor dysfunctions that were treated with trigger points. And you can see an improvement in waking up at night, constipation, painful sex, hesitancy. And that was in both men and women. It's always important to understand the cycle of how this occurs. Once you get a spasm within the pelvic floor, we talked about how that makes way for these urological symptoms. The problem is that when this gets started, the reflexive response of any human is to contract more, and then that worsens it. So it's important to utilize medications to break this cycle, and that's really, really key. And that's probably one of the most important roles of compounded medications in the treatment of pelvic health. And then this is just showing you that we're not just talking about the pelvic floor here. Things like interstitial cystitis and bladder pain syndrome can play a role in the pelvic floor, and more commonly, 70% of patients who have one have the other. Things like vulvodynia, IBS, fibromyalgia, recurrent UTIs, same exact thing. So you should understand how that association occurs. And then stress, we talked about it before, we're talking about it now, but I think it's probably one of the most related anybody can talk about in their life, because right now stress is at pretty much a pretty significant high. And with those elevated cortisol levels, you can also affect trigger points within the pelvic floor and have these symptoms absolutely exacerbated. Something that I think is really important is to understand the role of medications, but also understand the role of lifestyle modifications in treating these disease processes. The importance of peeling an onion. I'm not the kind of doctor that's going to throw a bunch of meds at you, because then we don't know it's working and we're kind of shrugging our shoulders like, did that work? Did that work? I'm not sure, but I feel better, or I don't feel better, and now I don't know what's working and not working. So try and limit your variables whenever you're looking at things like this. And then it's always a multidisciplinary team approach. So, there should be a compounding pharmacy in here, but psychologists, acupuncturists, GYNs, pain clinics, rheumatologists, all the stuff that you're going to be learning about in the next few weeks or months, is the reason that you're going to hear from so many people is because it's a multidisciplinary team approach, and the body is dynamic and it consists of different systems. And I think the biggest problem with modern medicine is that we focus on one area of the body as opposed to looking at the body as a whole. And I think if we do that more, we're more likely to come up with better treatment plans for patients. And this is it. This is just like a little humor at the end. And any questions, and I'm here to answer.
I'll just chime in. I totally agree with your multidisciplinary approach. That's how we like to look at things as well. You got to look at the whole person, what's going on. And I think most importantly, know your body, know what your stresses are. And then if you're finding into a relapse, you know how to then help yourself.
Exactly.
I think that's the education component that we can help patients with the most.
For sure. And utilize your resources at hand. We'll often have patients who I won't see in like a year or 2 years. And then sometimes they call up your pharmacy and they say, I need this. And then you guys are calling me like, Dr. Bahlani, have you seen this patient? You know what I mean? But it's because it's a team approach, and it's because we can help, but it's oftentimes understanding what the tools are in our toolbox that are going to be the most effective at that time.
Corinne, do we have any questions?
Yep, we got 2. So the first one, Dr. Bahlani touched upon just a little bit. It was, could you discuss the effect of menopause and hysterectomy on gastric and bowel function?
So, menopause or hysterectomy, or when we have a decrease in hormones within our body, such as estrogen, progesterone, and testosterone. And it's interesting because we're talking about menopause here, but this can occur in younger patients as well, can often affect bowel in many different ways, and bowel-based symptoms in many different ways. Number one, it can affect gastric motility. So it's often related to things like constipation. Number two, even if we take the hormones aside, although that's often related to kind of how our bowels move, it can also be related to bowel pain. And so you can also have pain within your rectum and within the bowels that can be related to neuropathic changes or neuropathic upregulation that can occur after hysterectomy or after hysterectomy or menopause. So there's so many different kind of modalities in which they're both affected. And that's exactly the take home point of this whole thing, that it's like, it's tough to give a whole, it's tough to kind of narrow that down, given that there's so many different mechanisms by which they interact.
Great. And then the second one isn't a question, but it says, as a health psychologist who works in integrated primary care and reproductive health clinics, I really appreciate the perspective you share on this. These are such common presentations I work with, and I love the way you present this to patients.
Oh, that's so nice. Thank you.
Yeah, if anybody else has any questions, feel free to ask in the chat.
And if you have any questions that come up after when we're done, you can email myself, you can email Dr. Bahlani. You know, just because it didn't get addressed now, you might get home and say, oh, I should have asked that question. Shoot us an email and we'll be more than happy to respond to that.
And I'll say one last thing, because I think it's important, because when we're dealing with different pelvic pain syndromes, we're dealing with, as we said, things like pelvic floor dysfunction, vulvodynia, interstitial cystitis. There's so many different avenues of pharmacologic care for these things. So we oftentimes will use topical medications. Even for my menopausal patients, I really don't like using just regular estrace that you get from a pharmacy, because there's 70% more androgen receptors within the vestibule, and you don't saturate those when you just use regular medications. But the problem is that this data is not shared with all of like the scientific community. So I will often compound my estradiol with testosterone, and I think it works a lot better. And so sometimes you have to have access to these certain things that might be kind of thought to be like, like one thing, like, what's that word I'm looking for? Like a one size fits all approach, but that really doesn't work. And oftentimes that's what sets apart a patient who does really, really well from a patient that's like, because I have so many patients that walk into my office, they say, I used estrogen, Dr. Bahlani, that doesn't work. Like, no, let's move on. And I'm like, well, you didn't necessarily use it the right way. And I think that's really key as well.
And I'll just add to that, I call those doctors who just do like cookbook doctors. They go down their checklist of medications that they use. They're really not thinking about the whole person, what's going on, and how I can really help that person. And even like patients who might be using estrace, if they have a reaction, it's not the estrogen, it's the base they're using. So it's really, like you said, peeling back that onion, trying to figure out what that patient needs and putting it together for them, but thinking. You know, I tell my staff this all the time. Think, you know, I don't want you to be a pill counter. I want you to think about the patient. I want you to think about what's going on and use the tools that we have to help that patient.
For sure, yeah. And, you know, and it's oftentimes the pH of the vagina can relate to pelvic floor dysfunction, can relate to recurrent BV or recurrent yeast. So I know sometimes I'll say, you know, you have the pelvic floor stuff, but you're also getting the recurrent yeast. Let's compound the boric acid with some Valium. So, you know, you have to individualize that approach, because if you're going to give people a slew of medications and say, here you go, this is what you need, that's not really good care. And oftentimes it's just polypharmacy. So it's important to kind of, like you said, peel it back and figure out what the best way to get the treatment that you need is in what form.
I agree. Does anyone else have any other questions? I guess not. Well, Dr. Bahlani, you were great, and your personality, your knowledge, it all comes through. And I appreciate you taking your time and being our first practitioner here. I'm sure we're going to have you back in the future. Maybe we'll do like a Mother's Day vulvodynia prior to Mother's Day, get everybody in good shape before that, and we'll be good to go.
Yeah, totally.
Right. And as I mentioned, any questions, don't hesitate to email, text, or call us. We're there for you.